Good afternoon today. My name is William Evans. I'm a neurologist and the medical director of the stroke program at Singing River Health System. Treat a wide variety of neurologic disorders, and today we're going to talk about spasticity. This is something that occurs after someone would suffer a stroke, and we're going to go through some of the treatments primarily focused on botulinum toxin. So spasticity is seen, again, in many conditions, so stroke, cerebral palsy, multiple sclerosis, traumatic brain injury, spinal cord injury, and even degenerative conditions. And what happens in spasticity is the nervous system is wired up so that the brain talks to the spinal cord talks to the muscles, and all of that works together. So when someone has a stroke, what tends to happen is there's loss of input from higher up in the brain to the spine, and the spinal reflexes take over. So, spinal reflexes are those types of reflexes that happen very, very fast. So if you put your hand on a hot pot and you jerk it away real quick, that's mediated at a very low level and allows us to function to avoid noxious stimuli. And so spasticity, again, is part of what we consider upper motor neuron syndrome. So upper motor neuron syndrome, someone could have weakness, and so that's sort of a loss of function. And then spasticity is sort of that exaggerated tone where the limb would get very tight. This is a diagram. It's a pretty noisy diagram. But what it's showing is just that there's pathways from the brain that go down to the spine, and then pathways from the spine to the muscle, and then there's even pathways from the skin, from the sensory receptors that go back through the spine and up to the brain. And so again, it's kind of a big feedback loop, and everything works together and allows us to have nice, smooth movements. And so again, in spasticity, what happens, we have these descending pathways, again, pathways from the brain that go down to the spine. And when those are disrupted, then the spine circuits take over, and that leads to this heightened tone. And so what happens, we call these anti-gravity muscles. And so a lot of times the functions you see happen is someone who has a stroke, they may have extension, so their leg gets real tight, it straightens out. And then oftentimes the arm flexes. So the arm flexes, the hands, the flex, the wrist flex. And so is kind of tightened up close to the body. There can be exceptions to these generalities depending on where the stroke occurs, but those are the most common findings that we see. And again, this is just another diagram showing this, and it's showing the brain again going down to the spine, and then it's showing, okay, we have this level of this injury. And so instead of the brain being involved in control, now we have these spinal circuits taking over. And this is just a picture or video, and I'll play this, and it shows someone who suffered a stroke, and you can see their fingers are flexed, their thumb is flexed, and all into their hand. And you'll see I'm holding the arm down there, and you'll see what happens when I release the arm. Arm just tends to want to do its own thing. And again, that's that anti-gravity effect. So it's flexion of the arm up into the body there. And so that arm is just continuously tight, pulled up into the body. And so over time, again, right after someone has a stroke, there'll be weakness for sure, but a lot of times spasticity is a more long-term process that sets in. And so there's stiffness, and then what contracture refers to is tendons and muscles tend to shorten down. So when they're constantly in that flex state, they tend to tighten down. And then you'll have muscle wasting because you're not using certain muscles. And then there's scarring or fibrosis. There's loss of function, there's pain, and then there can even be skin breakdown. And this is, again, spasticity. You can see those fingers that are flexed into the hand there. And so you can see the fourth and the fifth fingers, they're almost digging into the palm. And so you can imagine that becomes, quite a problem. Someone has fingernails and all, it can cause skin breakdown and cause wounds. And so when we want to treat spasticity, we want to minimize chronic deformities. If we can, we want to improve function and activities of daily living, or ADLs. Spasticity can lead to pain, so we can reduce pain. And then, if someone's helping someone have to get dressed, it's really difficult to help them put their clothes on if their arm is drawn up into their body and their hand is in a fist. And then again, as I pointed out in that last video, with the hand clenched up like this, hygiene problem also. Just able to open the hand can be quite, even wash the hand. And so there's a number of different treatment modalities we'll use for treating spasticity. And so bracing is one of them. And so bracing just helps compensate for the spasticity or the increased tone in one direction. So it may hold the arm out in a straight position for a certain amount of time. There's medications. Probably the most common medication we use is one called baclofen, and it's taken usually 3 to 4 times a day. Surgery, so if spasticity is very severe, then surgery, you can get tendon lengthening is one option. And then the medicine we just mentioned, baclofen, you can actually do what's called intrathecal baclofen. So what that is they put a little small tube and a pump that goes right directly to the spinal cord, and the medication is continuously released into the spinal cord. And then botulinum toxin or Botox therapy would be on that list also. And so usually it's a combination of these. So physical therapy, occupational therapy, Botox medications, then in severe cases, surgery and the baclofen. And so usually one of these will not suffice. We usually have to do multiple of these types of treatments. Here again is another situation. Someone has had a stroke. You can see their arm is flexed up. So, it's pulled up into their body. The hand is in a fisted position. And so you can imagine, that creates difficulty in terms of even putting a shirt on if the arm stays like that. Let me go back to that. Lift the arm up. So you can see it back towards you at all. You can see this gentleman still has function in the arm to lift it up, and he can pull, but he can't lift it up above his head as you would to put a shirt on. And then again, the hand is in a very tight position. And so botulinum toxin, it's a neurotoxin, and it's derived from Clostridium botulinum, which is a bacteria. And so if you were to take some of this systemically, meaning eat it, and this happened, it doesn't happen much anymore, but if this bacteria would get into like homemade canned goods or something and grows and creates the toxin, then someone could become completely paralyzed. They could stop breathing. And so, commercial Botox or botulinum toxin is very specifically manufactured. It's very accurate dosing, and we're putting it in the muscles, so it's not going systemically. It's not going out into your body everywhere, not getting into your bloodstream, and it's just staying in the muscles. And so there's different strains of this bacteria. And they make different toxins of different sizes, and they have different what we call binding properties, diffusion properties. That means how it acts chemically to get into the muscle, to what we call the nerve terminals, and the way it affects the muscles. These are just some of the commercially available ones that are used, and that's not extremely important. Sometimes we will switch back, and we'll switch from one to another if someone is not getting an optimal response, and maybe someone doesn't feel like it's lasting as long. And so sometimes we'll try a different toxin to see if we can get a greater benefit. And so Botox, botulinum toxin type A, there's also one called Xeomin. It has a number of different indications. So we talked about spasticity. It has upper limb spasticity. It also has lower limbs, so for leg spasticity. Now, blepharospasm is uncontrollable blinking of the eyes. So it has a indication for that. It has an indication for overactive bladder, for this hyperhidrosis, which is sweating, for strabismus, which is weakness of an eye muscle. So you're trying to straighten out the way eyes are. Chronic migraines, so patients that have greater than 15 migraines a month. There's a series of injections around the head. It hits kind of all the muscles of the head and some of the neck. And then there's the cosmetic, which is probably the best known use of Botox. And so this again is a patient who had a right hemisphere stroke. So when you're looking at this is a CT scan. When you're looking at a CT scan, the right side is the left side of the screen. So it's reversed. So this is where the stroke is over here. And you can see again, the hand is fisted up and the arm is wanting to pull back, and we'll try to extend, and we can extend some of these, but the fingers are very difficult to manipulate and to extend. And so in this case, gentleman is ambulatory, can do a lot of things. And so we want to try to relieve pain. We want to make it so he can take care of his hand, wash his hands. If we can gain some functional improvement, that would be great. We can't always gain functional improvement in terms of utilizing a weak limb, but sometimes we can. There's cosmetic reasons. It's some people don't would appreciate not walking around with their arm drawn up into their chest. And then again, over a long term, to prevent contractures. If a limb stays in a certain position over time, then the muscles, the tendons will shorten down, they'll scar down, and then you're fighting a very difficult battle at that point. And so again, this is the upper limb. The fingers are flexed, the thumb is flexed, just meaning bent into the palm, the elbows flexed, and then what's called the pronators. So the pronators are what sort of turns your, if you had your palm pointed towards the ceiling and then you turn your arm with your palm pointing towards the floor, that would be the pronators that do that action. Those tend to be overactive after a stroke also. And so those sometimes are muscles we would address. And this just shows some of the positions we can see. So a wrist, a closed fist, and then a flexed elbow over here. And so it's usually some combination of those, or many times all of those that occur. And then sometimes also the arm is kind of held tightly down at the side also. So it's difficult to lift the arm from at the shoulder. And these are just showing some of the muscles. The arm is fairly complicated. There's multiple muscles. And so if we started on this side over here, this is sort of what we call the superficial layer of the arm. And so there's muscles that lie right underneath the skin. Some of those flex the wrist, and then we get a little bit deeper. We get to some that flex the fingers, and then there's even some deeper that flex the fingers. And so we want to address many times muscles at all three of these layers. And again, just looking at an upper limb, so that this would be a biceps that would flex the elbow, so flex at the elbow. So that would be one of the muscles we would hit under that situation. So again, muscles involved most common. So the elbow flexors, again, so the arm is bent up towards you. The pronators, we talked about, that was the ones that would turn your palm towards the floor. The fingers flex, so again, making a fist. The thumb flex, again, making a fist. And then for the lower limb, the foot tends to turn in. The ankle tends to kind of push down like you're pushing on the gas. And then sometimes the great toe will kind of point up in the air also. And so this just shows a lower limb, and this is just showing this foot that tends to be kind of bent inward. And so treatment, again, therapy, splinting, we talked about medication, and then Botox, botulinum toxin. And so Botox now is approval for treatment of upper and lower limb spasticity. And so there's been studies, this has gone all the way back to 2004, revealed significant improvement in function and tone. So tone meaning, you know, the degree of tightness in the arm. And so it was able to relieve the tone. And then again, in some patients, if they have some function, you can improve that function. And this is just showing just some scales that use that are used that look at tone. And this is just going from 0 to 4 to 0 to 5, depending on which one of these scales it is. And so again, from, you know, someone with no increased tone all the way to a limb that's rigid and flexed or potentially extended for the lower limb. So meaning the lower limb would be straightened out, the upper limb would be flexed, and then there's 1, 2, 3 in between. This is showing post-stroke pain, and we won't go through all the details of this, but just showing there's a significant benefit, a significant reduction in pain after Botox. And you know, if you can imagine, you know, sitting there constantly contracting a muscle in your arm, that's kind of what happens after stroke. Is just some of those muscles are constantly contracting, and it can be painful for some patients. This is looking again at spasticity and just looking at the reduction of how tight the muscles were. And so these were looking down here at these clinical patterns and then global impression patterns, and these were both significant. So there were benefits versus placebo on all of those measures. And then this was looking at again, looking at a randomized study of Botox and spasticity, and just showing again a significant benefit. So 70-something% benefit versus placebo. So placebo, instead of, they still, they injected some patients with Botox, some patients just got the saline injection and did not get the Botox. And so just, that's how trials are done. So they try to keep the treatments that look exact, they try to make them look alike. And so patients in theory don't know which one they're getting. And so this showed a benefit despite a good placebo trial. And so what does Botox do? So it produces what we call a functional denervation of the targeted muscle. And so, you know, nerves talk to muscle, and they do that by releasing a neurotransmitter called acetylcholine. And so when you say, okay, I'm going to move my hand, the nerve sends an impulse down to the muscle, down the nerve, and then the nerve terminal releases acetylcholine, which makes the muscle contract. And so the duration of Botox, what it does, it stops this release of acetylcholine, and it lasts about 3 months. Some conditions like sweating, excessive sweating, which is, you know, you're injecting, you can inject anywhere for excessive sweating. You inject under the arms for it though, but it lasts longer for that. For the conditions we're talking about, post-stroke spasticity, it's about 3 months that it lasts. And this is just a picture, and it's showing these are what's called synaptic vesicles. So this is what happens in your nerve terminal. There's these like little balloons or little packages, and those little green things are what's called the acetylcholine. And so this vesicle moves towards the end of the nerve terminal. It releases this neurotransmitter right here, the acetylcholine, and then it excites the muscle right here. So the acetylcholine, it's kind of like a lock and a key. It turns the key and opens the lock, and then the muscle can contract. And this is all dependent on these little proteins right here that help this synaptic vesicle bind to the end of the nerve terminal. And so what happens in Botox is Botox kind of, it gets internalized into the end of the nerve terminal, and then it kind of busts those little proteins up. They're called snare proteins that help bind this vesicle with the neurotransmitter to the end here. So it's just not releasing. It can't release the key to undo the lock. And again, I tell people the good and the bad thing is that it's temporary. So, you know, sometimes you inject Botox and there can be unwanted side effects. If someone does have function, sometimes you can have some temporary weakness. But again, the good thing about that is it will go away. If it's helping a lot, the bad thing is it needs to be repeated. And this is again just showing inside of this nerve terminal where these little snare proteins they're cleaved or broken, and so these can no longer bind here, and it can't release the neurotransmitter out of the nerve terminal. This is just the upper limb spasticity, and again, not complete weakness, but just has some tightness in the limb. Here's sort of an area of damage in the brain over on the right side of the screen, but that would be the left side of the brain. And again, more area of damage right there. Let's see, turn it over for me. So you can see the hand is a little bit there, and then it's sort of slow to utilize. You can't get that one finger kind of closed all the way, and the palm is bent. Turn it back over. Okay, good. And so again, this will be a case, there's pretty good function there, and so we can hopefully gain some level of function, make the hand work a little bit better. And this is showing in the palm, you have some muscles in the palm here that actually, they bend the palm in half. And so we'll see that a lot of times in stroke. Not only is there sort of a fist, but the palm itself is bent. And again, this is just getting back to some of those muscles we addressed. So we're addressing, when the fingers are flexed into the hand, we're addressing these, the muscles that flex your fingers. Some of them live all the way up in the forearm, and then there's some that flex the palm that live in the hand itself. Make a fist now. This was after we did some Botox. Straighten it out now. And the hand just works a little bit better. It's not as bent in the palm, and the fingers work faster. And so Botox, just how it comes, and this is more technical, but we typically just dilute it with saline. So it's just kind of some physiologic fluid. It goes into, it's a freeze-dried type of compound that comes in the jar, and then we dilute it, and then we put it in a syringe to inject. And then when we inject it, we typically I use what's called electromyography. So what this does, it lets us listen to the muscle activity. And the reason that's important is, as I showed you in those pictures, many muscles, lie under or on top of other ones. And so we want to try to target the muscles that we want to target. And other ways you can look at that is you can use ultrasound to look at the muscles. Some muscles, like the biceps, they're kind of sitting right there. There's nothing really in the way, and you can inject those sometimes, without any type of guidance. But it just gives us increased accuracy. And this is just a video of how we'll be injecting right here. So at the bottom here, we've got a kind of a couple of electrodes, and then I actually have an electrode hooked onto the syringe there. And that's the muscle actually firing. So we're recording the electrical responses of the muscle. So those waveforms of the muscle firing. And so that helps again with the guidance, just to make sure we're in the right spot. The dosing we use, I usually like to start out on the relatively low side. Now, if someone doesn't have a lot of function of the arm, we're just trying to loosen it up, then you can go high right off the bat. If someone still has function, then you want to try to go on the low side, because you don't want to cause weakness. So for instance, if someone's able to use their hand to use a cane or a walker, you don't want to cause too much weakness in the hand. But the dosing depends on, again, muscle size, and then the level of overactivity. And it's usually a process. There's not a one size fits all. And so we would usually start with a series of an injection, and then we would change it over time, potentially. Then usually after 2 or 3 injections, you have it dialed in to what's working good, and then you can stick with that over, sometimes many years. It continues to work. And one thing about spasticity is not all spasticity requires treatment. So for instance, in the leg, leg being straight, if the leg is weak, the leg being tight in a straight position is actually helps with function because it helps support weight. So that stiffness in the leg actually helps with someone getting to walk again. So you don't always want to take all that tone up. So again, multimodal approach. And so Botox is just one part of that. So physical therapy, again, medications, sometimes bracing. And so sometimes if a limb has been, in a contracted position for a while, then sometimes we'll do Botox, we'll get someone in therapy, and we'll use bracing to try to get that arm loosened up. There are expectations, again, reduce pain, ease of care, hygiene, improve function. There's an asterisk on that. Again, if someone has, cannot move the arm at all, but it's just pulled up, we're probably not going to improve function there, but we may get it a little bit looser, and it may help with hygiene. It may help with preventing contractures. It may help with care. So it's not a one size fits all treatment. And that would be the end. And I appreciate y'all joining us